Hello and welcome. This is Dr. Wood, and today we're going to be covering Chapter 5, where we're going to discuss reading and interpreting medication labels. We'll talk about medication orders, things that are appropriate and inappropriate, and then finally some documentation in terms of things that are legal when you're actually writing or perhaps filling a prescription. So it's important to familiarize yourself with the components of a medication label so you can at least make heads and tails of what you're looking at. You're going to find that depending on where you're working in terms of what position you're filling, this may be more or less important to you depending on kind of what priorities you have there. But just to walk you through all the parts of a pretty stock sort of medication label you'd see in a product made in the US. First off, you're going to find letter A here is going to be the trade or proprietary name. Notice here that there is not a brand name available on this particular one. This happens to be a label for a generic product, phenobarbital, which is the generic name. A brand name for this might be something like luminol, but phenobarb is a pretty old drug, and so it's rare that you actually find the brand name product available for that. Up next, as I mentioned, we have the brand name, which is letter B, and then you have C, which is going to be the drug strength or weight. C here is going to be 15 milligrams. So based off of this, we know that phenobarbital is the generic name of the drug, and it's 15 milligrams, whatever it is, whether it's tablets, capsules, whatever the case may be. If this was going to be a liquid medication, this would have a concentration. So it would say something like 15 milligrams per 5 mLs or per 1 ml or whatever the case may be. D is going to be the form of medication. So here you can see it's for tablets as opposed to capsules or liquid, syrup, solution, whatever the case may be. Here it happens to be tablets. Notice here it says USP. That just stands for United States Pharmacopoeia. This just means that it's holding with the standards that the USP has set forth for medications there. This isn't super important for us in terms of interpreting the medication label, but you see that pretty commonly on a lot of drug products. E is going to be the route of administration. Here you can see the E is not technically on this label here, but if it says like oral solution or to say intravenous something or other, that would be what they're referring to there. So again, you're going to find that not every single label is going to have every single one of these components, but when you do see them, you can at least be familiar with them. So sometimes route of administration is present. And then F is going to be the amount of medication in the container. Here you can see it's 10 by 10 tablets. So this actually would come in like in a little blister pack, where you can imagine it would be in an aluminum foil card that had 10 tablets each. And then you would have 10 of those packets in this particular box here. If it was a bottle, it would probably say, number 30 tablets, something like that. This just indicates how it's actually coming in terms of its packaging there. Here's a different label for a Keflex oral suspension or cephalexin oral suspension here. Here you can see the brand name is present. So Keflex is the brand name. Cephalexin would be the generic name. This is actually an antibiotic that a lot of people are prescribed pretty commonly. When you have an oral suspension like this, you're going to find that a lot of times it comes in a freeze-dried powder. The reason why they do that is in order to enhance the stability of the drug so it stays better for longer, essentially. And so if you have a drug that comes as a powder, you have to reconstitute it and put it into a suspension, right? Remember, suspension are those ones where the particles will drop out over a period of time because it's not a completely homogeneous mixture, and so you have to shake those up. But here you can see that they'll have directions for reconstitution. So if you were to look at this, you could see directions for mixing. Add 36 mLs of water in 2 portions, that way you can kind of add 1 portion in, shake it up to kind of get the powder loosened up, and then add the rest of it. And when you add that amount of water, it will give you this concentration here, right? It's 125 milligrams per 5 ml. Notice here it gives you the quantity, 60 mLs when mixed. This is really important to make sure you add the correct amount of water, because otherwise if you get this concentration off, you're going to be giving the wrong dose to your patient for the entirety of that bottle there. Okay. H is going to be for the National Drug Code, or the NDC. This helps us to identify that it is a specific product. You'll find that you could have multiple generic products or brand name products that have different NDCs. This is really just will identify it to this particular manufacturer for this particular drug. Okay. Next, you have the expiration date. Always good to make sure that you're giving medications that are within date for your patients there. This is varying levels of importance depending on the product. Some drugs go out of date very, very quickly. Some other ones are good for a long period of time, but you never want to dispense out medications that are expired. Okay, if you had a label for controlled medication, if you look back on the previous slide here, if you look at the phenobarbital, you see here is the letter, or the letter K, denoting here the C for controlled substance. I believe we talked about that previously. This is a Schedule 4 substance, showing that there is some risk for abuse, and there is some risk for dependence, and you can see that here. They even put a warning that says may be habit forming. But again, that's how you know that it's a controlled substance. Always a big C with the Roman numeral in it. If this was a medication that had even more risk for dependence and abuse, then that might be a C2 or C3. Remember how that goes down in terms of risk for abuse. C5 being kind of the least amount, C2 being the biggest risk. And that would be for any kind of auxiliary labels things like, shake well before use. That way you know that because it's a suspension, you have to make sure you get the particles all into solution. Otherwise, you may find that you're just giving not much drug towards the top of the bottle, and then when you get down to the bottom, it's basically all the drug. So you want to make sure you let the patients know about those kind of warnings there to make sure they use the medications appropriately. So other abbreviations you're going to find for a lot of different medication labels out there. You might see a lot of letters, and those are typically stand for some sort of acronym. So for instance, things like SR stands for sustained release, controlled release. A lot of these basically mean that the medication is going to be lasting for a long period of time within the body. So say for instance, sustained release product, you may only have to give, say, instead of every 6 hours or 4 times a day, maybe only give it 1 time a day, or maybe twice a day. And again, remember that helps with compliance because they're taking it less frequently, so patients have an easier time remembering to take it. Not all of these are going to be for extended release products. So for instance, here the DS stands for double strength. That just refers to the actual strength of the tablet and not necessarily how long it works in the body. But most of the other ones tend to be related to that extended release sort of action. Other things you may see here are some of the labeling for over-the-counter medications. And again, a lot of people don't end up reading these as it turns out, but they will include a lot of information for the patient there, including a lot of things like adverse reactions they may have, the reason why they're taking the medication, things like, the how to dose it, when to take it, when not to take it, things like that. So these are commonly going to be included in a lot of the over-the-counter or non-prescription medications. Now, we use a lot of abbreviations in medicine, and you're going to find that not every single one of them is going to be all that safe, as it turns out. There's a lot of medication abbreviations that we say do not use anymore because there has been a lot of issues with it being confused with something else. This is a bigger problem when you had a lot of handwritten scripts going out there. And so for the most part, it's just easier just to write out the entire word. You don't necessarily have to shorthand everything, because if it causes confusion and then you have to clarify that, oftentimes you waste more time doing that than anything else. So here's a list of medication abbreviations you should not use, and this is by the Joint Commission. If you're familiar with the Joint Commission or not, they're actually a group that accredits hospitals, saying that they can get money from Medicaid and Medicare. It's really important that a hospital has Joint Commission accreditation, and if they don't, then that often means the hospital is not getting paid very well, and that's not very good for their bottom line. So this is really important. So if Joint Commission comes around and they see that you're using these pretty regularly, you can get cited for that, and that can be a big problem with whoever you're working for. Anywho, so here's some examples of ones to not use, and I'll tell you some of the common ones we run into from a pharmacy standpoint. One, writing U instead of just writing out the term unit. U can sometimes, if written, be misread as a 0. And so instead of, say, for instance, 10 units of insulin, it turns into 100 units of insulin, and that can be a really big problem, right? That could potentially kill a patient. Other things that I frequently see, especially a lot of my students, especially in the PA programs do, includes things like writing QD. Just write out daily. This can be misread as QID in some cases there, and so we don't like to do that. So just write Q day, Q daily. Daily is totally fine. Just don't ever use QD. Okay. Other things I see pretty commonly are going to be using zeros incorrectly here. And so in these cases, you never want to use a trailing zero. So if you, for instance, are giving something that is 5 milligrams, you don't want to write 5.0. You just want to write 5, because if someone misreads that, they could say, oh, it looks like 50 and not 5. So that's why we say no trailing zeros. This is correct here. And then lack of a leading zero. So if you were to say write 0.1%, ointment, someone can misread that and say 1% ointment. So instead, use a leading zero in those cases there. So 0.1, that makes it very clear in those cases. Okay. For verbal orders, this means that it's an order that is being communicated orally, and it's usually for a very specific patient for a designated medication. We really prefer not to use these because I don't know if any of you have ever played that game Telephone when you were in school, where one person says a phrase and they keep passing it down the line, and eventually at the end it turns into something completely different. Same things can happen here. So say, for instance, you were the prescriber and you say to the nurse to do this, and then the nurse relays that to the pharmacy, and the pharmacy hears something different. That can lead to medication errors, and so we really prefer not to use verbal orders. Most often we use this in cases of like emergent situations. So say, for instance, the patient's coding, they're in cardiac arrest, and we need to give medications very quickly. That's where we see a lot of verbal orders being used, but we prefer not to if possible. Always, though, they should be written down after receiving them. So it's really important to document those as soon as you can, so that way people don't forget things and people make sure that the right thing is being given. For medication orders, you're going to find that these should be written the majority of the time. And occasionally they may be verbal, as I mentioned in the previous slide here. But these are used a lot for inpatient facilities in order to give medication. So, for example, if you're in the hospital and you have a patient who's admitted to the med-surg floor and you're writing a medication order, these are going to be a little different in terms of requirements than you would see for, say, like a prescription you're going to give to a patient to fill at a Walgreens or a CVS, right? These are not being given to the patients for dispensing at the pharmacies. It's usually for the nurse to say retrieve from a machine to give to the patient, or retrieve from pharmacy, and then they directly give that to the patient there, right? And they could be either a standing order, where basically you have orders written on for the patient that says, if this happens, then do this. So as an example, if the patient has this sort of pain, say on a scale of 1 to 10, they have a pain score of 8, then you give them a dose of morphine, right? Things like that. Standard protocols are often used as well to help kind of expedite getting medications to patients. As an example, in our pediatric ER, we have the standard protocol for nursing to follow. So that way, if a patient develops or has a fever upon presenting to the ER, the nurse can go ahead and, under her protocol, go ahead and order some Tylenol, right? So in order to treat that fever right away, instead of waiting for a provider to come in to see them. Again, protocols can be either pretty lax or they can be pretty tight. It just depends on the situation and who's actually going to be acting on those protocols. So the components of a medication order, these are things that we'll commonly see here, including the date. So you want to know when the medication was actually started, the patient's name, and oftentimes it's going to have more than just this patient identifier. Very frequently it's going to have their date of birth. It'll have their medical record number. It's important to use as many patient identifiers as you can to make sure you're not giving it to the wrong person. You'll have the medication name, the dosage or the amounts of medication to give. So, your medication, amoxicillin, 400 milligrams, whatever the case may be. And then the route of administration, okay? This needs to be on every single medication order. And again, if there's ever any doubt as to which route to give, it is your responsibility to find out, right? Whoever's ordering that medication, if they write something that they're missing some of this information, you got to ask. Because if you make an assumption, oftentimes that can be incorrect and that can lead to medication errors. So just because you think, okay, well, this medication is always given orally, you must have to give it orally, but they never specified, that can be a problem. Actually, I had one case where there's a nurse who, there's an anxiety medication. It's called Ativan or lorazepam. It actually comes as either oral or it comes as IV. So depending on how the provider orders it, they may want the patient to either get IV or orally. And so this patient had actually had an oral dose of Ativan written for, and actually came in an oral syringe because it was a liquid medication. And so the nurse got that dose, and she was looking at it and she's like, well, this is weird. It comes in the syringe, but it doesn't really fit in with my IV syringes that I have here for the patient. Let me go ahead and just transfer this out into an IV syringe and then administer that. So the problem with that being is that the nurse was not looking at the order, did not see that it was meant to be given orally, and then she transferred it over to an IV syringe, and now you're giving an oral product intravenously. That's a big no-no, right? There's big sterility problems. There's big problems where that could damage the vein and the tissues. Huge medication error, right? So again, if there's ever a question, ask it. Don't ever assume anything, even if the doctor who ordered it is kind of a jerk. Like, you got to do it. You got to ask questions because that's what's in the patient's best interest. And then finally, you should have the time or the frequency of administration. So whether it's a now medication, whether it's to start later on in the day, how often you want it, if it's once, twice daily, whatever the case may be, these are all things that should be included on those orders. Now, for prescriptions, these are typically written more for like an outpatient sort of purpose here. So it's usually a written order for a particular patient. So it needs to be for a particular patient. And it's going to be written by a person who's licensed to prescribe medications. And there's a lot of people that fit that bill. You can have veterinarians, you can have DOs, MDs, nurse practitioners, PAs, optometrists, you can have podiatrists. I mean, there's a lot of people that fit that bill there. And so it's important, especially if you're on the pharmacy side of things, to make sure you know who's allowed to prescribe things, and that way if you get a provider who you're like, I'm not really sure they're supposed to be doing this, you can question that and know whether that's appropriate or not, right? And it's not only just for medications. You can have prescriptions that can be written for things like physical therapy, speech therapy, to go get an x-ray done, to get labs done. Prescriptions can be written for all sorts of things. We're mainly going to focus on the medication ones because this is a pharm class, right? And again, you may find that whoever is allowed to prescribe can change a little bit from state to state. In fact, you'll find that, especially for like the physician extenders, like the mid-level practitioners, like nurse practitioners and physician assistants, even that can range from state to state in terms of not that they can prescribe, but what they can prescribe. And in fact, Florida was actually one of the last states to make it so that nurse practitioners and PAs could actually write for controlled substances. We were really behind the times in terms of that. You'll find that a lot in Florida. In terms of medical stuff, we tend to be pretty slow on the uptake for a lot of things. So when you're preparing a prescription, and again, even though you may not be a prescriber, you may actually be filling a lot of these out for your physicians, right? Sometimes you'll have medical assistants who can be helping out with this. Scribes can sometimes help out with this. Ultimately, the provider is going to be the final signature on there, but sometimes you'll be filling it out for them, right? So basically, you're going to be recording the order in the medical record. So their charts should have some sort of record that you've written this prescription. And then the pharmacy will usually fill that, right? So they'll take it out to their Walgreens, CVS, Publix, wherever they go to, and the pharmacist will fill it there. But as I mentioned, you may be responsible for completing the prescription. So if that is your role, working with your prescriber, it's important to know what is required on that prescription, so that way they don't get phone calls later saying, hey, you're missing this, or this is wrong, or whatever the case may be. Now, one thing to note here is that prescribers must handwrite Schedule II prescriptions. So that's going to include a lot of like your heavy-duty painkillers, like your morphines and oxycodones. This also includes a lot of ADHD medications because most of them are going to be amphetamine-based. And so because of that, it's also a big deal. A lot of the students who are in school, even though you may think of like Schedule II substances as like hardcore narcotics, like it includes like your Adderalls and your Concertas. So there's a lot of people who are on Schedule II substances. It's important to know how to handle those scripts there. And again, depending on the state, you may find they may require triplicates of copies of prescriptions. They may require all kinds of different things. But wherever you end up working, you'll get used to those laws at that place. So the orders can be written for either, say, for instance, a compounding or mixing of medications. It could be a dispensing of a medication, or it could just be a dedication administration. So if it's, for instance, for like a one-time thing, say, for instance, like, a one-time order for the flu shot or something. There's only a one-time deal. It's important when you're writing out the prescription, they should either be on blue or black ink. Now listen, I'm all for people expressing themselves, but if I got a script that came in like neon orange or hot pink, I'm probably going to question them. It's like, are you sure you didn't write this? It should either be in blue or black, right? And honestly, to be fair, a lot of the scripts you're going to be writing these days are going to be computer generated. You can find that the signature may either be electronic, depending on the state you're working in, or you could even have a stamp being used there. This is for non-controlled substances, though. Controlled substances need to have an actual signature on there, specifically the C2s do. And actually, it's a really funny story. One time I was working with a relatively new pediatric emergency medicine doctor, and we had a computer system, where they would automatically fill out our prescriptions, and it would just get printed out, and she would sign it, and then everything was good to go. But our computers went down one day, as things tend to do, and so the doctor was like, "Hey, well, I need to write this script for this patient," and so I said, "Well, that's fine." And I handed her a blank prescription pad, and I said, "Okay, go ahead." And she goes, "No, I've never actually written a handwritten prescription before." And I said, "Never?" I mean, she's been a doctor for probably close to 7 years now. And she's like, "Yeah, I've never had to." It just never came up, right? Because that's kind of the generation that we're living in nowadays. But this is why we mention these things to you now, so you kind of have it kind of in your mind on how different things will be done. And if you get out there and you're in a profession where you're in school and you're doing rotations, you'll find that things are done very differently depending if you're in the hospital, if you're in the clinic, wherever you happen to be at, right? When you're writing these prescriptions, you can note that either one prescription can be on there for one particular drug, or you can sometimes use multiples. And I'll show you an example of what that looks like in just a few seconds here. So the parts of a prescription, things you're going to run into pretty commonly. You're going to see here, we'll go through each of these points here, but this is a basic prescription for amoxicillin capsules for an infection. Say, for instance, for an otitis media, or say strep pharyngitis, whatever the case may be, right? So let's get through the different points here. One, physician information or provider information needs to be present there. And again, if you're a PA or a nurse practitioner, whatever the case may be, your information will be on there as well. Note we have your address and we have the phone number, so that way we can contact you from the pharmacy if we have questions that come up there. So this is really important to include that. Most of the time, this is going to be pre-printed. Next up, we have the patient heading here, and so one of the things you'll note is when they have the patient name, it's really important to include things like their address as well, because the more identifiers you have, the better off you're going to be able to identify a particular patient. There's a lot of times you're going to have patients with the same name in your system, and so it's important to distinguish between them based off date of birth, based off address, etc. Note here the date that the prescription was written is really important here, because this will show you how long it's good for. So as an example, non-controlled substance, those scripts are good for 1 year. So even if the patient sat around and waited for 6 months to fill it, that's still a valid prescription there. They may end up losing some refills towards the end of it if it's a chronic medication, but the date you have to have on there, right? Next up is going to be the superscription. So this is actually the drug that is going to be prescribed here. And so you can see here, this is going to be amoxicillin, or amoxicillin is the generic name, 250 milligrams. That's basically the drug and the strength that we're going to be prescribing for this patient here. Next, you're going to have the inscription, and so this is going to be the name, the strength of the drug, as we're going to have actually the quantity included in each dose. So when you say number 30, this tells us how many capsules that we're going to need to dispense based on the prescription you're actually writing here, right? So the inscription tells us how much we're going to be giving with each particular dose. Next, you have the SIG, or the signature. Now, this is confusing because some people think signature, they think, kind of signing their name. In this case here, this is really referring to the directions for taking the medications. And here, you're going to see a lot of abbreviations being used. It's never wrong to write it out, but it can save you some time if you're having to write quite a few of them. So as an example here, the SIG is going to be 1 capsule TID, which you'll understand for 3 times a day times 10 days, right? And again, it's important to include the quantity to dispense, because you should double check along with this. So if it's 3 times a day for 10 days, that 3 times 10 is 30 equals number 30 capsules. That makes sense, right? Next, you have the subscription, and this will be any additional details to the pharmacist for filling. So for here specifically, that times 10 days gives us an idea of how much we're actually going to be administering, how long it's going to be given for, so that's why we include that there. Again, the SIG is the 1 cap TID, the F here is that subscription, that's how long we're going to be giving it for in this particular case. Then you have the prescriber's signature line. Again, this doesn't always have to be handwritten, but it needs to be present to be considered legal, especially for non-controlled substances. If it's a stamp or if it's electronically signed, that's going to be totally fine for our purposes in the pharmacy. Also note refills need to be here. This is really important to designate the number of refills. Even if it's 0, just write out 0 or none. You never want to leave a blank, because you could have a patient come in and write additional refills for themselves that you did not authorize. It's really important to consider that, especially if it's a medication where they may not want to come back and see you, or if maybe they want a couple extra refills just in case they get an infection again, whatever the case may be. That's really important to make sure you designate that. This bottom line here is going to be for the DEA number. This is not always required, but it is if it's going to be for a controlled substance. Again, you don't want to preprint numbers on here or anything like that. The less you can preprint on these is going to be better for you in terms of making sure that a patient doesn't come and steal it and tries to use it for their own purposes. So you want to keep that number kind of close to you if you do end up with a DEA number one day. Here's an example of a multiple script or multiple line prescription here. We can see you're writing for multiple things. Normally, you want to keep any of your controlled substance separate from that, and then especially any C2s have to be completely separate and just on their own individual script there. And you can see here they have the medication, they have the SIG, how they're actually going to take it, the quantity, refills, and then the provider would sign it here at the bottom at a DEA if it was for a controlled substance. So what if the patient runs out of refills on their prescription? Well, it has to be approved by the prescriber and documented in the medical record, just like a new prescription would be. So that way you can kind of keep track of it and see how long they've actually been prescribed that medication for. You'll find that a patient may show up at the pharmacy or they may even call the office directly and say, hey, can we get a refill for this particular patient, for this particular drug? That's a pretty common thing. So again, either patient can call the office, the pharmacy can call the office, whatever the case may be, and that way we can coordinate getting a new script. So let's say you're working at the office, the medical office, and you're getting a phone call from the patient. These are things you want to obtain from them whenever they're trying to get a new refill. And so when you want to document when they called and the date, you want to make sure they get the pharmacy name and the phone number. This is important because you don't want to send it to the wrong one, and then the patient goes to pick up their script and it's at a different pharmacy. It's going to be a big reason for a lot of complaints from them. Get the name and the strength of the medication, last time it was refilled, how they've been taking it, and then any kind of phone number so you can reach back to the patient in case there's a problem with insurance or something like that. It's really important to let your patients know, hey, at least give yourself 48 hours in advance for a refill. There's nothing worse than either being at the office or being in the pharmacy and the patient says, hey, I need a refill on this and I ran out 2 days ago. It's not great, right? In a lot of cases, you think of the mantra, a lack of preparation on your part does not constitute an emergency on my part, but because we are medical providers, we would like to go out of our way to make sure we take care of people. So as best as you can, try to educate them and let them know why it's so important to give us a couple of days of lead time in case there are problems with the insurance or the pharmacy or whatever the case may be. Now, in terms of the follow-up, not only the prescriber can actually approve a refill request, however, they may not always be the person who's calling up the pharmacy. A lot of times you'll find in a lot of states that medical assistants are able to relay that information. It just depends on the state and the laws and also the office, kind of how they have things set up there. And again, you'll find the prescriber will contact the pharmacy with the new order. And then once that's been approved or it's been refused, as the case may be, it's really important that the patient gets contacted. So someone from the office should call the patient up and say, hey, we got your refill all approved. We called it into the XY pharmacy. They said they can fill it by this time, whatever. Or if they refuse it, say, hey, listen, we decided not to go ahead and give you a new refill. The doc wants you to come back in and see him before we give you anything more. That's a pretty common occurrence as well, as you'll see. So if you have the privilege of having a prescription pad, it's really important to handle it pretty carefully. Do not leave it unguarded because people will steal things. And again, we don't like to assume bad intent on our patient's part, but you never know who you're dealing with, and people can steal things all the time, right? Ways that we can try to prevent counterfeiting is by using pads that have things like watermarks or pre-printed numbers on them, and making sure we're using the appropriate colored paper or ink to make sure it identifies it as being a legitimate script here. And don't just use a random piece of scratch paper. That's not really that appropriate. It needs to be on a legit prescription pad. If I were to get like a piece of, say, college ruled lined paper with a script on it, I'd be pretty dubious about that. I'd probably have to call and get some clarification on that sort of thing there. So in summary, in order to make sure you're increasing patient compliance, it's important to make sure you're providing good written instructions. So if you say, give something every 6 hours as needed, well, as needed for what? When should they be taking it? Make sure that you have the patient or whoever the caregiver is giving the medications understands the directions pretty thoroughly. And that's where I like to use that teach back method where I have them tell me how they think they're supposed to be taking it. Okay. Make sure they're using one pharmacy to fill out if possible. And this is tough because sometimes you're going to find that different pharmacies will have different prices depending on what the patient's insurance coverage is. And so they might shop around to try to get the best prices. We really encourage using just one pharmacy so that way all their information is just at one place and you don't have to try to grab it from a lot of different places. Make sure the patient confirms they understand what they're supposed to be doing, and make sure you give them time to ask questions. You want to make sure you're providing an environment where they feel comfortable asking questions, and that you're not acting like you're so rushed that you can't sit there and answer their questions, because again, that's really doing them a disservice. So up next, let's do some review exercises where we look at some example prescriptions and see how to interpret them, and then also the other way around, taking medications orders and then turning them into their appropriate abbreviations, if you were to say transcribe those down into a script. So first off, we have one for Keflex, 250 milligrams. This is an anti-infective, is used for a lot of different types of infections. It says Keflex 250 milligrams, number 20, SIG, cap 1 PO QID with food. How do you interpret that? How do you think that will be transcribed onto the bottle so the patient knows how to take it? Basically, it will get turned into Keflex 250 milligrams, dispense 20 capsules, right? So you can see number 20 on there. Take 1 capsule by mouth. QID is 4 times a day with food, right? The C, food, means with. C is always meaning with food. So that's how you would interpret this abbreviation. And again, this will become pretty easy for you once you kind of look at these enough. So get that practice and kind of look at a lot of these in order to get kind of comfortable. And this is why I'm including so many of these in these slide set here. Okay, and again, it doesn't really do any good if you just kind of listen straight through. So pause the video, give yourself a chance to really kind of figure it out, and then go forward to check to see how you did there. Okay. Up next, we have Breathine, which is a medication sometimes used for asthma. Breathine 5 milligrams, number 30, SIG, tab 1, POTID. What does that mean? Basically, it's for Breathine 5 milligrams. Dispense 30 tablets. Take 1 tablet by mouth 3 times a day. Now notice here we didn't make any, we didn't put any information about if to take it with food or not. That's totally appropriate. If it's important to take it with food, you would include that. If it's not really, if it doesn't matter, then you wouldn't include it at that point. Restoril, 15 milligrams, number 30, SIG, cap 1, HSPRN, sleep. So Restoril is actually a benzodiazepine, kind of similar to that drug Ativan I talked about before. This is a short-acting benzo that we oftentimes will use to help people get to sleep. How would you interpret this order? So basically, it's Restoril 15 milligrams. Obviously, we're going to dispense 30 tablets. And again, it's about a month's supply, right? Take 1 capsule. And actually, you can already see we made kind of an error here, right? It says 1 cap, but yeah, I put dispense 30 tablets here. So again, usually if we were to get something like this at the pharmacy, we would just go ahead and sub it out to the whatever dosage form we have available. This wouldn't be a make or break sort of thing here, but potentially we could call just to get clarification if we had multiple types that are available. So again, even us pharmacists can make boo-boo, so kind of take that with a grain of salt. Anywho, but we're dispensing 30 capsules. Take 1 capsule at bedtime, and then that PRN means as needed. And you want to make sure you tell the patient what it's as needed for, and in this case here, it's as needed for sleep. All right, next up we have naproxen, 375 milligrams, number 60, tab 1 TID. What does that mean? So we would interpret this as naproxen, 375 milligrams, dispense 60 tablets, take 1 tablet 3 times a day. Now notice here, this isn't a full month's supply, so sometimes you'll do that intentionally, but we may actually ask a question about that, because if you put refills on this potentially, that wouldn't really make sense. Normally, if you're giving a 3 times a day drug, we'd expect to see 90. But in this case here, it only worked for 60, so it'll only cover about 20 days or so. Okay, next, here, how to interpret this order. So furosemide, this is a diuretic or a water pill, 20 milligram tabs, number 90, 40 milligrams QAM, and 20 milligrams at 1 p.m. How would you interpret that? Basically, you'd interpret it as furosemide 20 milligram tablets, dispense 90 tablets, take 2 tablets every morning and 1 tablet at 1 p.m. Now, if you notice here, we're giving out the 20 milligram tablets, but yet we're telling them to take 2 tablets in the morning because it's 40 milligrams, right? So 2 of the 20 milligram tablets, and then just 1 at 1 p.m. there, right? So we got to specify that to tell them when to take how much at each particular time. We have micronase, which is another type of diuretic, 5 milligrams, 30 SIG tab 1 QAM, 30 minutes AC. So this would mean micronase 5 milligrams dispense 30 tablets. Take 1 tablet every day, 30 minutes before breakfast. Okay. Now, why do you know it's before breakfast? Because AC just means before food. We know it's breakfast because it says QAM. So again, breakfast being that morning meal. So that would be pretty reasonable interpretation. Malox Plus, this is actually an antacid preparation. 12 ounces, take 1 ounce, 2 tablespoons, 30 minutes AC, HS, and Q2 hours PRN heartburn. How do you interpret that? Basically, it's going to be Malox Plus is going to be dispense a 12-ounce bottle. You're taking 2 tablespoons, which is about 1 ounce. 1 ounce is 30 mLs, and a tablespoon is 15 mLs, so that makes sense. 30 minutes before meals and at bedtime, right? That's the HS part of that. So AC means with meals, HS means before bedtime, and then Q2H PRN is every 2 hours is needed for heartburn. Next, we have an insulin order. So Humulin R insulin, 30 units QAM, 30 minutes AC, and 20 units 30 minutes before supper. How would you interpret this one? So this one would be Humulin R insulin, take 30 units every morning, 30 minutes before breakfast, and 20 units 30 minutes before the evening meal, right? So supper usually means evening meal. One thing to note here is this should include the route of administration. And again, some of these things may seem pretty obvious, but this one should include things like subcutaneously. So I would say either inject 30 units or take 30 units subcutaneously every morning, 30 minutes, blah, blah, blah. Again, routes are really important to include on these as well. How about this one? We have aspirin, 325 milligrams, number 60. Tab 2, Q4H, PRN, HA, or fever. NTE 12 tab in 24 hours. What does that mean? This one here would be aspirin, 325 milligrams. We're dispensing 60 tablets, and they're taking 2 tablets every 4 hours as needed for headache or fever. So HA stands for headache or fever, but not to exceed, so NTE, not to exceed 12 tablets in 24 hours. How about this one? You have meperidine. This is actually an opioid pain medication, 50 milligram tabs, number 15, SIG tab 1, Q4 to 6, H, PRN pain. So meperidine, 50 milligrams, dispense 15 tablets. You're taking 1 tablet every 4 to 6 hours as needed for pain. So again, this is giving the patient a range. So if they need it sooner, they can get it sooner. If they don't, they can take it a little bit later, depending on how their pain is doing. Okay, so let's do it the other way around now. Let's kind of flip it and then look at the full order and then turn it into the abbreviations here, right? So the documentation exercise. So first off, we have digoxin, 250 micrograms, taken daily at breakfast. How would you turn that into an abbreviated form? Basically be digoxin, 250 micrograms, QAM with food. You say QAM AC could also be another way to do that as well. About indomethacin, this is a NSAID pain reliever, very similar to ibuprofen, 25 milligrams, taken 3 times a day with meals. It's going to be indomethacin, 25 milligrams TID with meals. Or you say AC, would also be appropriate. Next we have nifedipine XR. Now remember what XR means. It's extended release, so it's acting much longer. So normally nifedipine would be given very frequently, but here we're going to see it's 30 milligrams taken daily, so just 1 time a day. Basically, you'd say nifedipine XR, 30 milligrams Q day, right? Now remember, QD is not appropriate, so don't put QD on there. But you can say daily, Q day, any of that's fine. About Lopressor, which is a type of beta blocker, 50 milligrams, 1 tablet taken at breakfast and again at bedtime. How would you abbreviate that? Basically turn into Lopressor, 50 milligrams, tab 1 AM and HS. So we're showing they're taking 1 tab in the morning and at night. Acetaminophen, 325 milligrams, 1 to 2 tablets taken every 4 to 6 hours is needed for pain. That would be abbreviated as acetaminophen, 325 milligrams tab, 1 to 2, Q 4 to 6 PRN pain, right? So that way they have a range, how many tabs they can take and then how frequently they can take it. Maybe every 4 hours, maybe every 6, depending on how their pain's doing. Up next, we have administer cyanocobalamin. This is actually vitamin B12, 1,000 micrograms intramuscularly now to be repeated in a week. You'd say cyanocobalamin, 1,000 micrograms, IM stat, repeat times 1 week. So basically this is meaning give the one now, that's that stat demarcation there, and then repeat it in 1 week. Next we have procaine penicillin, give 600,000 units intramuscularly now. And again, how would you abbreviate that units? Would you just say U? Obviously not. You would not do that, right? Because that's one of those do not use abbreviations that the Joint Commission put out there. So here you can put procaine penicillin G, 600,000 units, write out units, IM stat. That means it's a one-time order, giving it right now. How about for a Z-Pack, right? Z-Pack is kind of interesting in the way that they're given. Basically, we're going to phone in an order for a Z-Pack. It's Zithromax 250 milligram tablets. It's take 2 tablets to be taken on the first day, followed by 1 tablet on days 2 to 5, 24 hours apart on an empty stomach. How could we abbreviate that? Basically, say Zithromax Z-Pack 250 milligrams. That denotes the strength of the tabs. Tab 2. Today, then tab 1 on days 2 to 5, 24 hours apart on empty stomach, right? You could say Q24 there instead of 24 hours apart potentially, and then just write out on an empty stomach. It's fine. Next, we're going to phone in an order for flagyl or metronidazole. This is used sometimes for different sort of bacterial infections, sometimes for parasitic infections, but we're going to be writing for 500 milligrams, number 14, 1 tablet twice daily for 7 days. Basically, you'd say flagyl 500 milligrams, number 14, tab 1, BID times 7 days, right? That tells us how long they're going to be taking it for. And again, that BID times 7 days should match up with the dispensed quantity of 14, which that makes sense. How about we're phoning an order for a cream? It's triamcinolone cream 0.1%. Notice here it's not 0.1%, it's always 0.1. You want that leading 0 on there. 15 grams, we're applying to rash 2 to 3 times daily, no refills. You would say triamcinolone cream, 0.1%, 15 grams. Note here that a lot of topical products could either come in ointments or creams or gels. So it's really important to note the dosage form. Here it's a cream, 15 grams, apply to rash, BID or TID, no refills. Here's an insulin order. So Humulin R, actually for 2 different types of insulins. So Humulin R and then Humulin N. Humulin N is actually a long-acting form that lasts for roughly 12 hours out of the day. Humulin R stands for regular insulin. It actually works very quickly, so that's usually given around meal times. So here's a case where Humulin R insulin 25 units in the morning and before supper, and then Humulin N 35 units every morning. And how do we write that for the medical record using abbreviations? Right, so here we say Humulin R insulin 25 units QAM and QPM. Or we could write before a meal, and then Humulin N 35 units QAM, right? So I'd actually write that as 2 separate lines to make sure that they note that as 2 separate orders. You would not want that to get confused and the patient to get Humulin R for both of those or Humulin N for both of those. That could lead to some severe either issues of hypoglycemia, being blood sugar is too low, or perhaps the blood sugar being way too high if they're not getting enough insulin action. And so that's it for this section here. Be familiar with the abbreviations and kind of what's appropriate, what are some of the do not use ones. That stuff, kind of stuff will come up on the quizzes there. Yeah, and if you have any questions, let me know, and I'll see you guys next time. Thanks a lot. Bye.